and start sharing my screen.
Recording in progress.
All right, is everybody seeing the screen? Just one nod will do. Yes, yes, somebody. All right, so shock team at the NBHC. So this is something, how did we get there? And how did we all start regarding this? I mean, this started a few years ago, and many of you have been waiting for some time for us to provide some data. And hopefully this morning I can provide a little bit of data to you. And this started before Chris White joined us in January of 2019. And it was really a desire to improve outcomes of shock patients. So our impression is shock patients in cardiogenic shock mortality was in the range of 30 to 60%. And new literature suggesting that perhaps a team approach rather than actual particular treatment could actually improve outcome. And then we initiated a series of meetings and by the stakeholders and really tried to come up with a strategy of how we would make this work for us at the New Brunswick Heart Center. And so these are the type of publications that have been coming out since the mid to late 2000s, 2000 teens. And this is from a Canadian, Sean Van Diepen out of Calgary, Edmonton, looking at really the contemporary management of cardiogenic shock. So beyond the sort of the way you think about, inotropes and the kind of things you might do is really how to approach it from different perspective. And our impression is, certainly at the Heart Center, is that clinical cardiologists, interventionalists, and surgeons and anesthesiologists, we all see things a little bit differently for the treatment of these patients, and how can we sort of use our strength to try to help them as best we can. And so we basically, on those meetings, we're able to agree on what would it look like to actually call a code shock on our CCU patients. And we eventually were able to sort of agree that, how do we define shock? And I'll show you a little bit more in-depth detail, the description of shock. But shock is not just hypotension. It has to involve also hypoperfusion. And that hypoperfusion is obviously means, I'm just going to mute a few people here. All right. And then once the patient is identified in CCU as having shock, obviously CCU resident is involved in the care, make sure the CCU staff gets looped in. But, a decision right away to make a code shock be called was really to get a three-way conversation between the interventional cardiologist on call, the CCU attending, and the cardiac surgeon on call. And really the goal was to have a plan of care at that point, from that point on, that would be decided amongst these individuals. Is it someone that we're going to escalate, and how far are we going to escalate, and how far do we go? And is this something that's salvageable? Is there some options here for interventions? All of those types of things. And this was really a trial for us. And so what I'll be presenting to you today is really a 12-month period in which we screen every single patient admitted to CCU for cardiogenic shock using the SCI, which is the Society of Interventional Cardiology scale for shock, and then assess within that context how many times was a shock team called and its utility. So this was a little bit of a monstrous amount of data to look at, and I'll show you some challenges and things that I would like for us to sort of going forward, things we could improve. So this is what a SCI stage of cardiogenic shock describes. What we think of shock is a stage C, which is classic shock, which often is soft blood pressure with evidence of hypoperfusion. Hypoperfusion means, low urine output, signs of end organ dysfunction based on that perfusion. A and B are, at risk or beginning, but they're not classified as shock, while D and E are sort of the deteriorating patient despite interventions such as inotropes, and extremists, which are patients essentially near cardiac arrest or dying. So you can classify every single patient in that manner. And so what we decided to do is every shift, every single patient admitted to CCU was to be screened and noted, and there'd be a record of that. And this is where I will need some help in the future to sort of, how do we move forward to make this data more readily available so that we can actually look in the future at how we do these things and how we improve our care. So using that approach, in that 12-month period, we screened, essentially there were 1,400 admissions to CCU during that period of time. and we screened the 85% of those patients. So screening was generally good. Unscreened patient, there were 240. And the shock patients, there were 93 that were classified as C to E shock. And I reviewed every single one of those. And 13 of those we classified as non-cardiogenic. They were generally septic shock, endocarditis, those kinds of things. And not on the shock team, then assessment, it was, you can see here below, and how many were activated or not. But I don't want to go into that part quite yet. So what does this mean? So if you look at this graph, it's really just to look at patients that were not screened, and it's just important. So I said 250 or so patients were not screened in the entire study. It is important to note that the bars, so the gray represent the non-screened patients. There's 2 months in the middle here that are quite a few patients are unscreened. And this happened to be in March of April of 2020, which was the beginning of the pandemic. So clearly things were disrupted. It was difficult for people to wrap their heads around continuing to screen on everyone. And it just highlights that when it's not part of usual care, and this is something extra that is done or asked, it is difficult to, one is keep the paper record, keep the a way for us to track it and to analyze it after. And at the beginning and end is where also some mis-screening happened, because people didn't think, is this a study ongoing, that kind of stuff. But in general, patients were screened virtually every shift for all of those patients. So screening was good. But screening, I think, is still critical to implementation of any treatment strategy around shock. Without screening, we can't obviously identify necessarily these patients. We're going to miss many. Overall, we screen, as I said, many. But if screening remains the part of care, how do we make it part of standard care as one? And this is where future efforts for us need to be. And documentation also needs the second part. And documentation doesn't mean I noted in my handwritten note on a chart that patient was screened. There has to be a data linkable, retrievable piece of information that we can actually then look at patient outcome. And this is where we fail as a medical system in general, is we make lots of notations and things, but we don't have the foresight to think of all this data, and then how do we do? And we don't analyze it. And hopefully I can push some efforts along that. And we've certainly applied for funding to achieve that in the next few months. So what proportion of patients had shock? I said 7% of patients, and the majority of those were classic C stage shock, but there were some D and E shock patients. So what does 7% of patient mean? Well, that means 5 to 10 a month out of 1,400 admission. That means more than 2 a week. So more than 2 patients a week in your intensive care unit and CCU at least have shock on a regular basis, or shock defined the way we have defined it in this particular setting. And I'm sure most of you working in CCU would know that sometimes it's every day, and other times there'd be several days without. So what is the mortality risk in these patients that were identified with shock? So this is in hospital mortality. So whether they died, and this is including the discharge institution. We ended up contacting every single institution where these patients were transferred back to make sure they made it home. So stage A and B, 2% mortality in that group of patients. So these patients obviously do well. In stage C shock, 25% in hospital mortality. Stage D, 55%. Stage E, no survivors. So it demonstrates how shock can be, and the overall was 33% of patients in that group. And remember, these will include patients that were hypotensive with a little required for hypoperfusion, with an acute STEMI that went straight to the cath lab, were revascularized and improved, to the patient with multivessel disease and shock, of which there was nothing to do. So this is the whole mixed bag of all of these patients. So obviously you'd expect some to do well, but some not to. And this is where it becomes difficult to sort out, what sort of strategies can you try to implement to help these patients? So geography, if you look at it, was also surprisingly did not appear to impact mortality. So the overall mortality for all patients is around 4% if you include all stages A to E. If you look at zone 2, the mortality for patients in shock was 40%. other zones 39, and non-Brunswickers, which are really PEI, 31%. So many of us might imagine that patients in shock coming from PEI actually have a worse outcome, but certainly in that small group of patients, non-adjusted compared to the group here did not appear to have a major difference. Remember, these are unadjusted outcomes. So what about the shock team? Well, how did we do and what happened? This is just to sort of look a little bit at the nitty-gritty more information, but you can see here that shock team was activated in 35 out of the 80 patients that we classified as stage C to E. So that's 44% of shock team patients. The only thing that's worth noting, so the average age of patients in both groups were not that old, mid-60s. Whoops, I'm just going to mute a few other people there. There were still some patients that were older than 70, so there's a wide spectrum of them, so about 30% of them, but not very different between groups, except that in the shock team activation, there were slightly more patients that did not reach significance, but trended towards 2, that came from other regions than region 2, and they were generally more advanced stages of shock. So the non-shock team activation were the ones that were sort of around stage C and perhaps had an intervention and got better right away, while there were quite a few more stage D and stage E shock patients in the shock team activation. Just a tidbit. So our tendency is to activate the shock team when things don't look good. It makes sense. We seek for help and ask for help. It makes sense in that setting. Whoops. So what did the shock team result in? Well, the shock team, a few tidbits of information here is shock diagnosis on admission was not all the time. So remember that patients can develop shock while in hospital. And actually, in fact, in the entire study, it's about 2/3 of patients develop shock on admission to CCU, or have shock on admission, which makes it easier for people to notice and identify. But 1/3 of them develop shock while they are in CCU during that stay. So that's a much harder group to identify because it can happen any time of day or night, at any point. And obviously the outcome may not be quite as good. But so activation of shock team did result in more invasive lines and more intervention. Not surprising, if you activate the shock team and you want to answer some questions, and I'll provide some data to that. Arterial line was used in 90% of those patients, and central line 94%. PA catheters, less than half. And overall, you can see in the NOx shock team, very few patients use a PA catheter. Cardiac catheterization, PCI, TAVI, or surgery, even IBP or ECMO, so these are mechanical support, 18 out of 35 did end up having mechanical support. So activation of a shock team does predict use of mechanical support more often. Mortality, as pointed out below here, while a little bit lower in the shock team activation, despite being further down the shock pathway, did not result in a significant improvement in mortality. Not that we set out doing the study at showing or demonstrating improved mortality, because these are unadjusted patient groups. You're comparing apples and oranges, but it does bring some things to mind. I want to talk a little bit about the less than 50% PA catheter use, because it is something that often is debated and we talk about, but just to illustrate why I think this is important a little bit, is the use of PA catheter, while in the general ICU population is relatively felt to not necessarily impact outcome. In the shock population, there is certainly data to suggest that in that management of heart failure patient and shock, PA catheter can be very helpful in managing these patients. And I know this is often a matter of debate, but this is why this is important. And when we get called or we get asked to see from a shock team point of view, we're looking for data and information. And data and information will drive decision. And this is just a little bit of an example of an algorithm to show that is, echo and PA catheter gives us filling pressure assessment that we can assess truly and as best as we can, both right and left heart function and volume status and output and resistance. And all of the therapies that we decide are going to be based on that, whether we help the left ventricle only, the right ventricle only, both ventricle, whether we need to deal with systemic vascular resistance more, whether we have a bit of volume options. So all of those things are critical. And so often a shock team, that's why it results in all of these potential invasive lines is the value of the invasive line is in the decision making, and this is where the value is. And I know Chris would be certainly a strong advocate of that. So, I showed you data that shock team did not appear to impact outcome. I hope I'm not conveying the message to all of you that we should throw out in the garbage the shock team, because to be honest, from my point of view, while nothing is perfect, I do like making sure that we communicate as best we can. There are clearly some patients we can't help, but there are some patients that we might be able to help, and that discussion is quite helpful. And then we all learn and potentially impact these people that are still very challenging to help. So what about other factors that could have been associated with mortality? And this is where I don't have yet all the data, and hopefully those are the kinds of things I need to be looking at in further detail. Is, geography, I was able to, I think, suggest that distance did not appear to be a factor, but maybe these patients just self-selected themselves. They never made it to us if they were that sick. The ones that made it to us were the survivors, and that's why it didn't impact. The shock team itself did not appear necessarily to have an impact on mortality on unadjusted outcomes, but there are some data from elsewhere that does suggest that perhaps there's an impact, but maybe the impact is not immediate. There's certainly the Ottawa group were able to show no difference in in-hospital mortality, but showed that 6 months or a year there was an improvement in survival in these patients. So what about process of care? And what I mean by that is what about such things as the PA catheter and those kinds of things? And does that impact on outcomes and how we manage things? Time of day, does it matter if it happens in the middle of the night, on the weekend? Can we improve our coverage? Can we improve how we help each other? And time delays and unexpected delays are clearly an aspect that is of importance. And how do we minimize those delays the best we can? So I'm looking for systems level changes, not obviously individual practitioner level changes. This is where, as a system, we can make things and facilitate diagnosis, communication, and intervention. This is really where the benefit will be. And why are these things important? You've seen the slide before and some of the talks from Chris before, in cardiogenic shock, delays, in terms of intervention, sort of for mechanical support, if you were intervening in less than 13-hour shock state initiation, your survival was much better than a certain threshold. Here was 13 hours, but there's lots of studies many studies that have shown that the impact of time and shock on end organ function and your ability to recover. And this is where we need to focus on how we intervene on these patients. So there's more analysis to be done. This is an important quote from Osler: observe, record, tabulate, communicate, use your 5 senses. A little bit different in those days. Learn to see, learn to listen, learn to feel, learn to smell, and know that practice alone can make you an expert. But it also, for me, in my mind, highlights that, we need to record these things. And unfortunately, I'm giving you data on a 12-month block that we had a great opportunity to measure things for that 12-month block, but it's not ongoing. We're not continuing this. And while some people say, yeah, we're screening our patients, there is no record of that screening. I don't have an ability to say that we're doing better now than we did then. And this, in my mind, is absolutely crazy. We need to be monitoring, measuring, finding ways, use our IT systems. And this is where we need to change the way we do things. But that's another conversation. So what are the take-home messages or major themes? Screening, we're able to screen. Our nursing staff are great at doing that, and they're really the key to this, at least 85% of the time. And if it becomes part of practice, it would become 100% of the time. Shock is common, 7% of all CCU admissions, and only 65% of them were diagnosed on admission. So vigilance is still important. Mortality is high, 33% overall with stage D and E, 100% in stage E shock patients. Shock team mobilized in 44% of cases. Maybe there's a missed opportunity here. Maybe more should have been involved, maybe not. Have we really nailed down where the benefit is highest? I don't think I have. So clearly shock team results in more invasive monitoring, more interventions, but I wasn't able to show you a mortality benefit. But again, unadjusted outcomes here. So I don't think I caused harm. Hopefully we provided some benefit. So if we're going to continue to impact change, again, I know I've said this many times, we need ongoing screening. We need ongoing efforts from everybody. We need data capture on the screening process. And this is the only way that we're going to be able to look at the outcomes in the future and how we impact the care of these patients. And with that, I'm looking for anybody who's willing to help on this all the time. Thank you. I'll stop sharing and open this up to question.
Just wondering
Rob here. Just